Hello, everybody. Thank you for joining us. Just a couple announcements before we start. Make sure to join our listserv for updates and our newsletter. Make sure to add us on LinkedIn and link us as one of your experiences. Follow us on Instagram, and just a reminder, we've updated the quiz time to 48 hours. So make sure to take your time and fill out the journal and quiz questions correctly. Now it's time to introduce our presenter. Raquel is a registered dietitian specializing in surgery and critical care. She completed her undergraduate degree at UMD, Go Turks, and received her master's degree from the University of Rhode Island. She is also a certified nutrition support clinician and currently works at the Hospital of the University of Pennsylvania in the surgical ICU.
Awesome. Hi, guys. I think everybody can see me. So my name is Raquel. I do live in Philadelphia and I currently work at Penn, and I did do my undergrad at the University of Maryland. I'm going to talk a little bit about kind of the journey to becoming a registered dietitian, what that looks like, what a dietitian is versus a nutritionist, do a little background on what we do when we're seeing patients, consults, and then I'll take you through a case study, which I really like, kind of showing how we moved from like an oral diet through enteral nutrition to parenteral nutrition. So I'm going to share my screen. Can everybody see my screen? Yes, awesome. Okay. So this is my journey to becoming a registered dietitian, but everybody takes a similar path. So I did my undergrad at the University of Maryland in Dietetics. During that time, I had a few internships. Most undergrad students do some type of internship programs, do some sort of volunteering at a hospital or, different food programs as they can. And then once you've completed your undergrad degree, there's a matching program kind of similar to a residency where, you list your top choices, they list you, and then you get matched with the program. I matched with a company called Sodexo, and I did my internship in Philadelphia at some various hospitals. If anybody's heard of any, like Chestnut Hill, Hahnemann Hospital, which unfortunately closed, and a few other places. The dietetic internship consists of 1,200 supervised hours. You get experience in community nutrition, food service, and clinical nutrition. So my program was very heavy clinically. Some programs aren't so much. So there is a little bit of diversity in what you can choose. And then once you've completed your dietetic internship, some internships are paired with a master's program and some are just specifically the internship itself. But so once you've completed that, you take an exam to become a registered dietitian through the Commission on Dietetic Registration. And once you've passed that, most states require state licensure. Some states, like I know New Jersey actually does not, so you can practice there without a license, I should say. And this is kind of what differentiates a dietitian from just a nutritionist. So someone can complete their undergrad degree in nutrition and say, yes, I'm a nutritionist. Some states, you actually don't even need that. You can just say you're a nutritionist, without any schooling really. But an actual registered dietitian that's licensed and in the hospital and that you'll meet has gone through all of these steps. I myself specialized in nutrition support, and there's actually a few different things that a dietitian can specialize in if they choose. There's sports dietitian, a diabetic educator, there's a geriatric specialization, a renal one, and also in oncology. So that just requires an exam and some hours that you've completed to get that. And then I also did a graduate program online at the University of Rhode Island to get my master's degree in dietetics. So there's certainly different areas that a dietitian can go into after completing all of this. I kind of mentioned earlier, there's like community-based dietitian, there's all kinds of different programs, and there's state programs like WIC that dietitians can be involved with. Some may work at even like a gym or in food service at, a company that has food service running their cafeteria. There can be dietitians working there. There can be outpatient dietitians, private practice dietitians, all kinds of things. I work as an inpatient dietitian at a hospital. So most hospitals use a floor-based coverage for dietitians, where you take ownership of a floor. And yeah, you probably have most of the same population of patients coming there, but you can kind of get a mishmash of patients and you just take them as they're on your floor. At Penn, we actually do service-based coverage, which is really nice. We have it broken out into different teams. There's actually, I think, like 26 or 28 of us at Penn. So it's quite a large group. I'm on the surgery team, and within the surgery team, there's like 10 different services. And the services listed here are what I myself cover. So I cover a trauma service, thoracic surgery, GI surgery, and endocrine and oncology surgery. And with that, we follow the patients wherever they go. So if they're on the floor after surgery, if they go into the surgical ICU afterwards, we're following them no matter what. So that's a nice continuity of care for us. And let's get to my day today. So coming into the hospital in the morning, we screen the consult list. So I'm pulling consults that are for my services. I also have a list of patients that I'm following. So I add those to my list for the day. Who are the people I need to see? For the follow-ups, we have, mild, moderate, and severe follow-ups. So the severe patients and patients that are in the surgical ICU, we're seeing definitely 3 times a week, maybe more, depending on the situation. So I gather my list of people I'm seeing, whether that's consults or follow-ups. I'm collecting information on them, looking them up, speaking with the providers, many times going to rounds to discuss with different, people in the hospital. I go speak to all of my patients or check in, see what's going on. That usually takes a few hours in the morning. And then I come back and I chart all my patients, make changes as needed. We do a lot of education series, which is really nice. We have a great education program just within the nutrition department. So Penn is really research heavy based. So we're doing a lot of that, kind of keeping up with everything. We also precept a lot of interns and students. So we are getting students from those dietetic internships in the area. So, we're part of their supervised hours. So that's nice. So this is a really big chart, but I wanted to kind of, I know you guys don't get a lot of nutrition in med school. So I wanted to kind of take you through a little tiny bit of the research and explain kind of how we diagnose malnutrition, why it's so important, how we come up with our calorie and protein needs, and lightly touch on enteral and parenteral nutrition, which again, you'll see in the case study. So this is how we determine if someone is malnourished. This takes into account criteria from the American Society for Enteral and Parenteral Nutrition and the Academy of Nutrition and Dietetics. On the left side of the screen is kind of how we diagnose moderate malnutrition, and on the right side of the screen is severe protein calorie malnutrition. Within each of those, we're looking at whether it's acute, chronic, or due to social or environmental circumstances. So when we're going to interview the patient, we're asking them about their intake over time. We're asking them about their weight loss over time. And we're typically doing a physical assessment. So we're looking for fat loss, muscle loss, if there's any edema. Grip strength is mainly used in the outpatient setting. If the patient's in the ICU, they're not going to grip something for us. And it's not something that we're really going to be carrying around with us, which is a small tool. So by, looking at all of that, we're looking at, for example, the weight loss percent over time. So if a patient, lost 10% over 6 months, we would calculate that as moderate malnutrition. That would go to that criteria, but maybe they lost 7% over 6 months. So we don't recognize that as significant, but we're still looking at everything else going on. Have they not eaten in 7 days? Do they have severe muscle wasting and fat loss? So you kind of have to gather the whole interview and then kind of make your decision. So malnutrition documentation is needed for reimbursement through CMS. So sometimes doctors will be pulling this into their note. And depending on your electronic medical record system, sometimes it'll pull it in for the doctor already, depending on, if we've written our note or not. And I know that there's a lot about albumin out there. We actually do not use that as a marker of nutrition status. It changes so much with fluid, inflammation, surgery, trauma, acute, anything going on, it's going to fluctuate, and it's not an accurate marker of nutrition status. So I just want to throw that out there. So assessing calorie and protein needs, there's about like 50 different predictive equations out there, and a meta-analysis determined that a quick estimate is just as good. I don't know if you guys have heard of any, but like the Ireton-Jones equation, the Penn State equation, Harris-Benedict, there's so many of them. And so we're just really using, for a typical regular weight floor patient, we're using 20 to 30 calories per kilogram. In the ICU, we're using a little bit less calories, especially if they're on the vent. And there's really no definitive data for obese patients, whether that's calories or protein. Our goal is really to just support lean body mass for those patients. And it's also important to note that obese patients can absolutely be malnourished. Just because you can't see it doesn't mean that they're not malnourished. Taking into account, again, maybe they're in the ICU, they haven't, they've been NPO for 5 days, and they've probably lost some lean muscle mass. So we would still use that and say that that patient is acutely malnourished. So for those obese patients, we're using their actual weight for a BMI of under 50. And then once we hit 50 and above, we're using their ideal body weight, which is calculated using their height. And for protein needs, a typical person needs about 0.8 to 1.2 grams per kilogram, like you or I, that's what we would need in a day. In the hospital, it's a lot more protein that we're trying to give the patient, especially after surgery or trauma. We're going upwards of 2 grams per kilogram. For CRRT or ECMO, we're getting up to the 2.5 grams per kilogram. We also want to take into account wound losses and drainage, which we're making up for about 20 grams of protein per liter of like abdominal vac losses. So just taking into account all of those things. Again, we're using ideal body weight for obesity for protein. Okay, so a little bit about enteral nutrition. If the gut works, we want to use it. That's a nice phrase that you'll probably hear over and over again. Using enteral nutrition tube feeds. So we kind of switch back and forth when we're saying that. Some people say like TEN or enteral nutrition, total enteral nutrition, tube feeds, anything. They're all the same thing. So it prevents gut atrophy. It's less expensive than parenteral nutrition. There's decreased infections and decreased permeability and decreased risk for bacterial translocation. There's several routes for enteral nutrition. I actually like this picture. It's pretty nice and kind of shows you all the different routes. Really, for us, when we're thinking about tube feeds, we're thinking gastric versus postpyloric or small bowel. So there's a few differences in how we're choosing to feed when we know what the route is. So for example, gastric feeds, we have, NG tubes, OG tubes, PEG tubes, open gastrostomy tubes. So for that, we can do bolus feeds or continuous feeds. So continuous feeds are typically a lower rate over a period of 24 hours. Sometimes it's cycled down to like 12 hours in cases where, the patient may be eating something, maybe the speech pathologist came on and they can eat a, full liquid diet, nectar thick liquids. They're probably not eating that much, so we still want to support them overnight with tube feeds while they can eat some during the day. So that's nice with the, gastric feeds. So we can do bolus feeds if we need to, or cycled feeds. So for postpyloric or small bowel, so that's mainly just jejunostomy tubes. But so that we can only do continuous feeds. It's going into the small bowel. That makes sense, right? And that we can also cycle, but the max rate to go through a jejunostomy tube is about 150 milliliters per hour. A typical tube feed regimen varies, based on calories, but I'd say is probably between like and depending on the tube feed formula, how dense it is, but it's between like maybe 40 milliliters an hour to like 100 milliliters an hour over 24 hours. That's kind of where you're at. So, you know, if the patient needs 100 milliliters an hour over 24 hours, you can't cycle to 12 hours because they're not going to be able to get 200 milliliters an hour. That makes sense. So we do like enteral nutrition. We try to use this as much as possible. Obviously, if the patient can eat orally, we do that. And we kind of try to help them transition as we can, depending on what's going on. So for parenteral nutrition, if we can't do enteral nutrition, we can't obtain access. They have an intolerance to enteral nutrition. I think our surgical ICU is really good about if the patient isn't meeting their needs through enteral nutrition for maybe 3, 4, 5 days, they will consider doing parenteral nutrition. You know, maybe they have to keep stopping for procedures, or the patient's just not tolerating it, they're getting bloated, their abdominal exam is changing and it has to be held. So at that point, we want to switch to parenteral nutrition. Obviously for intestinal failure, bowel obstructions, mesenteric ischemia, short gut syndrome, all of those things, we're going to need parenteral nutrition, fistulas, anything like that. So we do want to have a dedicated central line for the patient to receive parenteral nutrition. I should note that we do have peripheral parenteral nutrition as well. We typically are not using that just because it's peripheral access. It needs a lot of volume. And we, you know, especially in the ICU, we typically don't want to be giving that much volume. So, and with good line care, good ongoing management of the line, there's no greater risk for infection by just getting parenteral nutrition. You have the same risk of infection just by having the central line in, no matter what's going through that central line. So the makeup of parenteral nutrition, I don't know if you've ever seen it, but the bag on the screen is typically what it looks like. The milky white color is actually coming from the lipids that are in there. If you remove the lipids, which you certainly can do, it's more like a yellow clear color. And that actually comes from the multivitamin that we have. So if you take the multivitamin out, then it's like just a clear water looking solution. So the makeup of parenteral nutrition, this is where, you know, we're broken down to basically just our macronutrients, right? So we have protein, fat, and carbohydrates. So amino acids are our protein, dextrose is our carbohydrate, lipids are our fat. At some institutions, you cannot manipulate the electrolytes. And even some institutions, you can't manipulate the macronutrients as you want to. There's some institutions where they're using like premix bags, which is a little scary because each patient is totally different. But here we write the prescription specific to the patient. We're able to manipulate the electrolytes, not in peripheral parenteral nutrition, only in total parenteral nutrition can you manipulate the electrolytes. Super important. And the additives we have a trace element package, we have a multivitamin package. We can add like thiamine, folate, vitamin C, zinc, selenium. So we're adding some of those things, you know, depending on what's going on. If there's wounds, we like to add vitamin C and zinc. If the patient is at risk for refeeding syndrome, we add thiamine. And typically we're starting with a lower amount of dextrose in those patients. Refeeding is really the only like nutrition emergency that we would ever get called for. And so that's where we want to go a little bit slower on the nutrition, and we want to make sure to replete electrolytes prior to starting the nutrition. All right, so we're going to get into the case study. This is a super interesting guy that I've been following along with for quite some time. He is on the thoracic surgery service. So he's a 41-year-old male with end-stage achalasia. He had an esophagectomy in June of 2020. He came back to us in, I think it was late September, early October. His admission weight was 61.1 kilograms, BMI of 19.9, which is on the lower end of a regular BMI. And I diagnosed him with severe protein calorie malnutrition using the criteria I kind of reviewed earlier. He wasn't eating a lot of his meals, so PO intake of less than 50% of his meals for a week. excuse me, he had severe 10% or 16-pound weight loss over the last 4 months. So, that's just based on his weight, the 10% we're getting. And he had moderate temporal and clavicular wasting and moderate subcutaneous fat loss on my physical exam. I calculated his needs. So I did 30 calories per kilogram because he's in that normal range. And I did 1.5 to 2 grams per kilogram of protein. At this point, he was, 4 months after surgery. He hadn't had a surgery just yet. So I was okay to calculate a little bit lower than that 2 grams per kilogram at the time. So he was admitted with a productive cough with nausea and vomiting, which later we kind of realized was not actually vomiting, but all of the mucus that he was coughing up. We started parenteral nutrition, which I'll denote as PN. We initiated that due to concern for an esophageal perforation. So once I started the TPN or the PN, I used 30 calories per kilogram. So we were near that 1800 and 2 grams per kilogram of protein. So there I have my, sorry, my doorbell just rang. There we have our regimen that I put for when he first started. Let's see. And then touching on the different types of lipids we have is also important. So for him, I had SMOF lipids. So that's a newer type of lipid that's available here in the US. Typically we, or historically I should say, we were really only allowed to use 100% soybean oil, which can be really inflammatory, but that's really all we had. So now we have this thing called SMOF, which stands for soybean oil, MCT oil, olive oil, and fish oil. So it's a really nice mix. There's research that shows less time on the vent, lower triglycerides, lower LFTs using this, less infections. So I definitely wanted to use this for him just because I knew that he was gearing up for surgery as well, and his triglycerides were elevated at 191. Then he had an EGD with biopsies demonstrating chronic gastritis. We did place a J tube or a jejunostomy tube. After his esophagectomy in June, anytime a patient has an esophagectomy, they get a J tube. And that's because they have to be NPO for typically about 2 or 3 weeks after surgery. So really they're only getting their nutrition from tube feeds, but that's typically removed once the patient is shown that, they're eating well, they're back to their regular diet. So we had to place that again. We started a standard formula, and I'll talk a little bit about the types of formulas at the end because he kind of transitions through a few of them. So we started on just a standard tube feed formula. Patient started having diarrhea, and we held the parenteral nutrition because he had started on this tube feed and was doing, besides the diarrhea, well and receiving his nutrition. Then he had a dilation, and they saw multiple fistula between his gastric conduit and his lung. So you can kind of see there on the side, there's a small fistula. I think you can see that. It's a little hard to see, but and then he was still having diarrhea. So we had GI come on board. I went through his medication list. A lot of times it's not actually the tube feed causing the diarrhea. There could be sorbitol and medications that are going through the J tube, definitely can cause diarrhea. We want to rule out any infectious sources before we transition. The standard formula that he was on did not have any fiber. So I transitioned him to a peptide-based formula, which is just a little bit more broken down. It does contain a little bit of soluble fiber. And so we were trialing him on that. Then we resumed parenteral nutrition because they were concerned for an ileus or an obstruction, which didn't end up being anything. So then we wanted to restart him on enteral nutrition, but he was refusing due to nausea and the vomiting again, which was more his coughing up the mucus and diarrhea. Then a few months went by, still receiving a combination of tube feeds sometimes and mostly parenteral nutrition. They attempted a repair of the fistula with a stent, didn't work. So finally in January, he had a colonic interposition, which I have a little picture of here, and they placed a new J tube. So they actually also left the old conduit in. So he has 2 conduits, right, and attached to his small bowel because he had the esophagectomy previously. So really kind of paring down how much intestine he has left to absorb some things. So for this, it's important to think about, you know, the patient now has less colon, so less room to absorb water and fiber. Then the patient was transferred to the surgical ICU for respiratory failure and was intubated. He was on propofol. So propofol actually does contain lipid calories, and depending on how much they're on, they can get quite a bit of calories just from the propofol. So he was still on parenteral nutrition. So I actually removed all of the lipids from the parenteral nutrition just because he was making up for it from the propofol. And that's pretty much the only major change I made at this point. I was always monitoring his electrolytes and changing those as needed, but he still had pretty much a normal, you know, electrolyte package here. So you can see sodium chloride, he had 80 milliequivalents, potassium chloride, 20 milliequivalents, calcium, 10, magnesium, 20. He had a little bit of sodium phos and some K-phos in there as well. So while he was vented, we were able to start some trickle feeds, which was still that peptide-based formula that he had kind of been trialed on previously. We were able to do that through the J-tube, and he was having some diarrhea. He did have a fecal management system in, so we were able to kind of track that a little bit. So at that point in the ICU, he's had this colonic interposition. He's really not tolerating the peptide-based formula. I transitioned him to an elemental tube feed formula. The problem with elemental tube feed formulas is they're a low calorie formula, typically low protein as well. And this patient is a surgical patient, needs a lot of protein, but at the same time was still receiving parenteral nutrition. So I wasn't overly worried about it. I more wanted him to be able to tolerate the tube feeds without having diarrhea. So now he's getting both things. He's getting this elemental tube feed formula, mostly at the rate he needs to be at, and he's also getting parenteral nutrition. So I pared down a little bit on what I was giving him. Still no lipids in the bag. I came down a little bit on the protein. So I was giving him 1.5 grams per kilogram in the parenteral nutrition and a little bit less dextrose. Then finally, a few days later, we were able to totally discontinue the parenteral nutrition, and he was solely being fed through his J tube. And then he was extubated. He did have a swallow study showing a small leak. At this point, so here, I guess I should point out, are my tube feed formulas. Yeah, the doorbell rang. Nutrient 1.5 was the standard one I was originally talking about. Most patients tolerate that, especially if it's gastric. A J tube, it's hit or miss with the patients, but I do like to start with that. Honestly, more for insurance purposes than anything else. And if they tolerate it, great. It's a more calorie dense formula. The Peptamen is the peptide-based formula that I was talking about with a little bit of soluble fiber. It's higher in protein. That's a 1.2 calorie formula. The Vivanex is the elemental formula. That's the 1 calorie, low fat, low protein. You need a really high rate to meet any nutrition needs. So on the floor for him, this wasn't really working out. He needed a really high rate. You know, at this point, he's up, walking around, needs PT, and I needed to cycle him, meaning, you know, getting less hours, but the same amount of nutrition. So in the end, I tried this. It's a newer product, actually. It's called Complete Peptide 1.5, and this actually has plant-based protein. So as opposed to all the other ones that are more of a whey protein. And it also has MCT oil, which makes it a little bit easier to digest. Doing amazing on this formula. We're able to cycle him, getting all of his nutrition, doing really well. They eventually advanced him to just a bariatric clear liquid diet. So he still needed his tube feeds, and he was discharged to an LTAC. So really interesting guy, kind of showing the progression from enteral, parenteral, kind of back and forth, doing both. It's like everything changes every day. So it's always interesting, these complex surgical patients. And just looking back overall, you know, in college and throughout my dietetic internship, the biggest thing is just to be open to new experiences. If you want to see something or someone offers to, show you something or shadow them or round with them, just say yes. You're going to learn something. It might be something that you end up really liking. And also utilizing the experts available. I feel like this is more just coming from me talking to like people coming up in med school as well. Like, we want you to call us. We want to talk to you about the patient. Like, we're going to learn from you. You're going to learn from us. And just communication is really nice. Talking to the whole team. I'm always talking to like the speech pathologists and PT, seeing what's going on, the respiratory therapist. So it's all, being open and talking to everybody and getting all the information you can is just what I would recommend looking back on my experience so far. Okay, does anybody have any questions? That was fun.
No, that was great. I was never really exposed to anything like that before, and honestly very, very cool and interesting.
Awesome.
And I have protein shakes that just look like those
little cartons.
Yeah. So that got me a little excited.
Nice.
We do have some questions.
Awesome.
First, we'd like to know, what does the matching process look like? And what sort of things were you looking for when you were comparing one program to another?
Sure. So the matching process, I guess I was mostly looking at location and clinical hours. So I already knew I was really interested in inpatient nutrition. So I wanted like the heaviest program in that. And I know University of Maryland has a program. I think it's more like tech like related. So I wasn't necessarily as interested in that one, but so you do that, you have interviews, you have visits, it's an application, and then you kind of match each other. And there's like a match day, there's the whole thing just like that as well. So I hope that answers that question.
You also mentioned something that interested me earlier. You deal a lot with GI tract surgeries and types of things, and you mentioned that absorption could be a problem. So obviously, no matter how much you pump in, they're not really going to be absorbing as much. How do you adapt to that, and what are some challenges that causes?
Yeah, so GI can be really, really, really complex, and each patient is really different. We can always mess with the tube feed formula. I didn't touch on it, with the case study, but he was also on something called ProSource. It's like a protein modular. And a lot of times those aren't really well absorbed or tolerated. So kind of, it's really just trial and error sometimes. And also knowing if a patient, for example, has short gut syndrome and it's a brand new, right after surgery, this is their new diagnosis, that's going to take a really long time for the gut to kind of adapt and start absorbing things again. So in that case, we would do parenteral nutrition. The patient would go home with that probably for a very extended period of time. But always trialing food as well, kind of seeing how the patient tolerates food. After certain GI surgeries, you're going to be on, a clear liquid, full liquid diet, soft foods. We have a lot of education that we do with patients, for example, after like a total gastrectomy or a partial gastrectomy. We're avoiding dairy, we're avoiding alcohol, we're avoiding fiber, and then we slowly start to add those things back in. So it's always a process for patients that have difficulty tolerating things. And it's also very individualized. So, some patients might tolerate dairy right after their gastrectomy. It just totally depends. And inpatient, it's difficult to specifically help them because they're only there for a short period of time. But if it's, a cancer patient, they got their gastrectomy, they're following up with an outpatient dietitian, they're a lot better at helping them with specific foods and kind of growing their variety of food back up.
We have a question from our audience. Nick C says, what was the condition for the case study? What was the diagnosis for it?
So he has a gastric, it's a little bit complicated. He has a gastric conduit fistula to his lung. So since he originally had an esophagectomy, he has a gastric conduit, and that's what fistulized to the lung. So it would be like an esophageal pleural fistula, but that's not really what it is because he has the conduit. So fistulas is, I guess,
I understood some of those words.
Yeah.
I do have a question about how you treat malnutrition. So you mentioned that there's environmental factors and there's
Mhm.
lifestyle factors. So how would that change? For example, if you're dealing with a patient who has not malnutrition because of, let's say, like urban deserts, right, where you can't really get that much nutrition,
Mhm.
versus somebody who just has, I don't know, Crohn's, or somebody that has even a lifestyle difference or choice.
Yeah. So we typically see like the social environmental issues more in like the medicine patients, not to say it doesn't ever come up in surgery, but at that point it could be potentially like alcoholism, food desert, like you're saying, the patient is elderly and they don't have help at home, like that's when we would kind of use that designation. And a lot of times we're able to get social work involved and help us with meal programs. We have a supplement program where we discharge patients with like oral nutrition supplements like Boost or Ensure. If you've ever heard of those, we can discharge a patient with those, which is really helpful. But we're really not ever solving their malnutrition in the hospital. It's not a long enough period of time, but at least we can hopefully set them up to go home and be a little bit more successful.
I do have a question. You mentioned that you have sort of like researching or education briefings, and I've been hearing a lot about like gut flora and how much that is important to like physiology, and how like it helps in a whole bunch of different things. Like, is that something you consider, or is it just the research is too early on, or anything like
Yeah. So the research is too early. There's a lot coming out now about the gut microbiome and how much that's affecting pretty much every disease state and everything that's going on. The American Society for Parenteral and Enteral Nutrition just had their conference these past like 4 or 5 days, and there were quite a few presentations on that. So I think it's definitely up and coming and something really interesting that we're going to keep an eye out on.
Another question we have is, you're on almost, you're following the patient around, pre-surgery, post-surgery, like I said, PT. What is your interaction with other physicians or other healthcare professionals look like, and how do you manage all those inputs and try to put them into your own planning?
Sure. So the way we have it set up at Penn, there's a lot of advanced practice practitioners. We call them APPs. So a lot of PAs and a lot of NPs, which is really nice to also work with the residents. So each team has assigned APPs. So in the morning, I'm looking at my thoracic consults. I know I'm going to call the thoracic NP. So I'm typically rounding my list with each team in the morning, letting them know if I have any changes to a parenteral nutrition order, or asking, what the update is for the patient. So that's nice. So you know exactly who to go to. In terms of working with speech, we work really closely with them. They want the patient to eat, we want the patient to eat. So we're always kind of talking back and forth, what can we do to get them to eat? Maybe they're on a restricted diet. I can only do so much for them. I'm calling them, hey, like, how was today? Do you really think that they were too lethargic? Like, can we try again tomorrow? So we're always like talking back and forth. And then like respiratory therapists, I didn't touch on this at all, but we have indirect calorimetry at Penn. So that's measuring the REE, or the resting energy expenditure. And so we order that for the patient, and the respiratory therapists do the test for us, and then we read the test. So we're talking with them, maybe the patient's not even eligible, maybe they have some sort of leak, air leak, and we can't do it. So we're definitely talking to each member of the team. And I think it's certainly important to talk to them all as well.
And it just seemed like there were a lot of moving parts
Yeah.
there, and I was really interested in how like you were adapt to that.
Yeah.
We have a question, moving gears back, about early exposure or interning, like you said. We have somebody that wants to know how you found your early opportunities to, I guess, shadow or intern, and what that exposure looked like with dietitians.
So I think I had, let's see. Oh yeah, I did list. So I did have a internship or I guess really a paid job at the USDA and also at the Food and Supplement Nutrition Education Program. So those were just things that I applied for online, something that I was interested in. I wanted to do something in nutrition. I also was able to volunteer at GW Hospital. So just, I was kind of always looking for opportunities, connecting with whoever I could. Just, I know it's really difficult actually to find certain opportunities, but even just volunteering, if you can take some time, that looks really good on a resume. And even just good to get experience. Like I was volunteering in the hospital. I'd never worked in a hospital before. So that was nice to kind of get my feet wet.
And when you were getting those opportunities, you're probably exposed to a whole bunch of different specialties. And you said you specialize in support dietetics, right?
Yeah, nutrition support.
What are some other specialties that you were considering? How are those? What were the differences between that, and what made you land on support?
So I specialize in nutrition support, and nutrition support just means enteral and parenteral nutrition. I just found it the most useful in the inpatient setting. It's extremely interesting to me and I love doing it. So I just figured that that was probably the best thing to do. If you're working in oncology or on an oncology floor, you're probably going to want to get your CSO, which is certified support for oncology. So there's just once you figure out what you want to do, there's most likely some sort of certification or specialization that you can do. So that kind of comes second, like doing the exam. Once you've figured out that you want to do it, you do need hours. Like for diabetes educator, you need a ton of hours doing that first before you can even get your certification.
And you mentioned earlier partitional. I hope I'm saying that right. Nutrition. It seemed a little bit invasive. Does that have any type of long-term effects on the body, or does it really, do anything? Or
Parenteral nutrition?
parenteral. Yeah, I'm sorry. I'm really bad.
No, that's fine. I know. It's like this new word. So you need a central line. So anything that comes with a central line could potentially be a long-term effect. We can't do PICC lines, peripherally inserted central catheters, for somebody that might need dialysis access one day. So there's definitely little things. I mean, if you get a clot or something, that's probably not great, but you may need a central access for antibiotics or anything else. So I want to say no to that question. I want to say no.
Okay. Yeah, I was just curious because it seems a little invasive.
Sometimes. Yeah.
And you mentioned it was more like a kind of like last second thing.
But you're worse off if you're malnourished. There's a ton of research to show that malnourished patients have much poorer outcomes. So you want to feed the patient, even if it's parenterally.
Right. You're not healthy if you're dead. I totally agree. I am curious about if you're comfortable talking, your personal and professional lives and the work-life balance. And I want to know if how it is for you, and if it feels like a sacrifice or yeah.
Sure. I actually feel like my work-life balance is pretty great. It just works for me because I'm someone who will absolutely procrastinate. So for me in the morning, I have my list of 10 to 15 patients I have to see, and I check them off when I'm done. And that's pretty much it. We're doing education and research and all this other stuff, but it's nothing that I'm really taking home. We're on call when we work on the weekend. But like I said earlier, the only real nutrition emergency is refeeding syndrome that the doctors can typically figure out themselves. So it's not like we need to be called, all hours for anything. So it's nice.
Yeah, that is actually really nice.
Yeah, it's great.
And you mentioned a lot of staying up to date with current research and technology and best practices. What is the most interesting thing that has come up, or what is the biggest piece of research, I guess, that's might be changing the field soon, or maybe years in the future, or anything you see, evolving in the field in a couple of years?
So the most interesting thing that I think will be coming soon is dietitians reading CT scans to diagnose malnutrition and sarcopenia. So seeing loss of muscle mass through that and fat loss. So that's going to be really interesting because right now, we're doing a physical assessment, but you can't see everything. It's more subjective than anything else, but that would give us like actual proof. And that is coming soon, I think, in the next couple of years.
Is that like a hospital barrier, logistical barrier, or is it just you need like a?
I think it's logistical and educational as well. Like we don't read scans. So someone's going to have to teach us how to do that and, let us become experts in that, I guess, and like trust our judgment on that if we're the ones that are going to be reading it. So I think it's going to take a little bit of time, but I think it will certainly be useful.
Yeah. On the same framework of like reading charts and everything like that, how do you read a chart, and like what are the thoughts that are going through your mind, your thought processes, and like what do you think for like what can wait now, what can't wait, and like you said, like a refeeding syndrome, like a possible critical situation, like what is your decision tree on that? How do you like navigate through something like that?
Sure. So first things first, when I'm looking at like a new patient, I'm checking the weight history. I'm seeing if there's anything from a prior hospital admission or an outside hospital admission that I can see. So I'm kind of already in the framework of, oh, this patient has lost quite a bit of weight. Like I kind of already know what I'm walking into. Like they're probably going to be malnourished. I'm looking at their labs. I'm looking at their medications to see if there's anything nutrition related. Looking at their past medical history. And if there's any past nutrition notes or anything that I should be aware of. The second part of your question, what was it?
I was just like, yeah, like just guide me through of like you're reading the chart, you're like, okay, this and that, like, okay. All right, this person probably, yeah, like you've been doing.
Yeah. Great. So I guess it also depends, the patient. I also obviously look at what diet they're on. Maybe they're NPO for something, maybe they're just on clear liquids. So again, okay, so I know that maybe they're already malnourished. I'm thinking, okay, if they're on a regular diet, I'm going to have to add oral nutrition supplements. I'm going to ask them if they want Boost or Ensure. If the patient on my GI surgery service, I have a lot of bariatric surgery complications. So if some of those patients come in or an obese patient that I definitely think would be malnourished, I have like a bariatric failure to thrive panel that I can do. So that's looking at like all sorts of vitamins and minerals and seeing if they have deficiencies. So that's all things I'm thinking ahead, like, oh, maybe I'm going to order this. And in certain circumstances, I'm like, okay, we have a really low threshold to initiate parenteral nutrition for this patient. They come in with a small bowel obstruction. They're a tiny little old lady. Sure, we could wait 7 days, but that patient's probably already malnourished. So maybe we should think about doing it a little bit earlier. So I guess that's kind of my thought process.
Yeah. Also, when you also mentioned the educational part of when you have those interns around, could you talk a little bit more about that and what type of like training that you do with them, or any advice you give to those young dietitians that you have with you on rounds?
Yeah, so usually they have their clinical rotation split up into like some sort of service. So a lot of times they'll be with me for like GI surgery or nutrition support, the enteral and parenteral nutrition. So at that point, they usually know kind of our charting system. They have a thought process for how to assess the patient. We call it medical nutrition therapy. And we have like, SOAP notes and that's kind of the process that they learn in school, kind of how to assess. And so at that point, they're going around with me, or maybe they're interviewing the patient already by themselves. We're reviewing, how to calculate calories and protein for certain disease states. They're probably going to give me what they think the nutrition regimen should be, what tube feed they would pick, what rate they would pick, and we'll review that together. And then at that point, they're usually writing their own notes, and it's something that I would co-sign after we've reviewed it together.
Okay, yeah, thank you. I was curious.
Yeah.
I was wondering if it was more like hands off, like observational, or if it was more like a mentoring thing.
Mhm.
Um, we I know you mentioned earlier about obese patients or how uh, people think they don't get malnourished,
Mhm.
and you try to work on like the lean muscle. What are some issues that you have to deal with obese patients, or any type of challenges that might occur? Because I feel like having to deal with one implementing a lot of the GI stuff, you have to think about how it's going to affect their weight or anything like that. So
Yeah. I mean, sometimes body habitus gets in the way of certain accesses and looking at different things. So occasionally we'll have to deal with that. I guess it also depends on the service that the patient is on. Like I said, my GI service has a lot of bariatric surgery complications. So they kind of already know what's coming. They know the patient's malnourished. They haven't been eating. Of course, they want to lose weight immediately after bariatric surgery, but like they still need fluids, they still need protein. So in that sense, the services are pretty good about it. The way we calculate the calories and protein for an obese patient, we do keep the calories pretty low, but we want to make sure they're getting adequate protein, um, whatever route they're getting it through. So I think that's important. I don't know that I run into that many issues with people not believing that they're not malnourished at this point. I just like to bring it up because sometimes it's missed, I guess. And using our malnutrition screening tool, you could probably make a patient malnourished by the time they've been in the hospital 5 days if you couldn't do it on admission if you suspect that they're malnourished.
yeah, like, so I was just a little curious about any issues that might pop up there.
Yeah.
And since we are in a quarantine and we are virtual, I have to ask the topical question. Has COVID changed any of your workflow? Has it affected anything? Or is it more just you have to put your mask on and just, keep going to work?
Yeah, I mean, at first it was certainly weird. We actually weren't going in to see the COVID patients. We can look at the feeding pump from the outside of the room through the window and see what's going on. Obviously, we're talking to nursing all the time about the patients, and they're the best resource. So it wasn't necessarily difficult, especially if the patient was like intubated, sedated. We can do tube feeds and parenteral nutrition pretty easily just from a visual of the patient. What was more difficult was if the patient is eating and awake and we can't really get in to do an interview. So we were calling the patients. We have cell phones. So I was, standing at the door like, hi, like, please pick up, like, answer my questions. But now we're going in the rooms, like, now it's fine. And yeah, it's like, wear your mask, we wear goggles. Now it's really not that different.
Okay. We are reaching towards a little bit the end of the time. So a question we like to ask all our physicians. I know you gave a little advice at the end there, but I want to rephrase it a little bit.
Sure.
If you had your undergraduate self standing in front of you right now, what would you tell her? It could either be like nuggets of wisdom, advice, or anything. Just imagine you're talking to you right now. I'll even mute my video.
Oh man, I don't know. I think kind of what I said, like, just be open to new experiences. There's gonna be physicians and people that don't agree with you, and you just have to make sure that you're doing what you feel is appropriate. You're advocating for your patient. You do what you need to do, and you try to work as a team as much as possible. I think that's what I would say.
Poetic. Thank you so much. I want to thank everybody for coming out today. We're going to have the quiz in the chat. We're going to have everything that I mentioned before, the listserv, the LinkedIn, everything is going to be in the link tree in our Instagram. Join us next week, I believe, for our next shadowing session. Thank you for everybody for coming out. Be sure to like and subscribe, all that good stuff. And we will see you guys later.